Uh, Thank you, sir, for the kind introduction. Good afternoon, everyone. And first of all, I wish to thank the organizers for giving me this opportunity. I feel honored to be present here and to deliver this oration today. About a month ago, when I received this email and when I got a call from Dr. Aman that, Ankur, you've received this oration, I was like very excited at that point of time. And soon after that, I realized, oh, I have to give this oration. This is my first time I'm delivering any oration, and what I'm going to speak about. Then I talked to a few people, and I realized that, they told me that, delivering oration are not that exciting. And then, I was just thinking over last 1 month, what should I speak about so that I can keep everyone busy for the 30 minutes of my talk. So before I move on to the subject of oration today, I wish to give a very brief journey about my academics throughout since 2005, when I joined my graduation in SMS Medical College, Jaipur. So my graduation days were, I think, more about finding potential, finding out within myself that if I am in a position to actually become an academics, into an academics post. And I think by the time I finished my MBBS, I was very certain, whatever happens, I just want to be a pediatrician. And one man who influenced me most during my graduation days was Dr. Ashok Pangadia. He was the principal SMS Medical College at that point of time, and he was a renowned adult neurologist. During my third prof, I won a dermatology, state-level dermatology quiz, and my dermatology consultant took me said, let's go and meet Dr. Ashok Pangadia. He said, I still remember his word, he said, winning a quiz may not be a big thing, but this may actually be a beginning of something big. And I think those words somewhere clicked me, and I think I never looked back after that. Soon after completing my MBBS, I joined as an MD Pediatrics in Maulana Azad Medical College. And I wish to acknowledge Dr. Monica Juneja, who was my thesis guide during my MD training in pediatrics. And what I learned from her was the passion, and her passion was autism spectrum disorder. So what I learned from her, that whatever you do in your academics, you have to be passionate about that particular disease. Although she would be very unhappy with me, she was very unhappy with me that I'd never pursued pediatric neurology as a career, and I never pursued autism spectrum disorders as a career. But I think this is what I learned from her, that you have to be passionate about what you do in your life. And I also wish to acknowledge Dr. G.R. Sethi. When it was about my farewell time in MD Pediatrics, when Dr. Sethi asked me, what next do you want to do? I said, I want to go to PGI Chandigarh. He said, what in PGI Chandigarh? I said, at that time, I want to do pediatric hemato-oncology. He said, why not go and meet Dr. Surjit Singh, and why not pursue pediatric clinical immunology and rheumatology? To be honest, I had no idea at that point of time what pediatric immunology and what pediatric rheumatology is. During my MD days, I had never seen a case of JIA. I had seen just one case of Kawasaki disease and probably one case of X-linked agammaglobulinemia. So that was all my exposure in pediatric immunology and rheumatology was at that point of time. And I still remember getting one question in my exam on approach to primary immunodeficiency diseases. Now we know left, center, right about primary immunodeficiency diseases. At that point of time, I was clueless what to write about primary immune deficiency diseases in that question. But I think what Dr. Sethi said was very right, and he had some background about immunology and rheumatology, and I think what he wanted to say that there is a need for people to go into this field and pursue this field in future. And then I went into PGI Chandigarh, which is the mecca of academics in India. I joined there in 2014 as a senior resident, and within a couple of months, I had made up my mind that yes, I want to do pediatric immunology and rheumatology from this institute. And within a year, I joined as a DM, and then soon after completing my DM, I joined as a faculty in the same unit. What I want to acknowledge most in my life is Professor Surjit Singh. He has been my mentor, guide. He has not only taught me to become a academician, a researcher, but a good human being. And he always taught me what to do, and more importantly, what not to do in your life, as a human being. So I really acknowledge him I think what I am today, I'm standing here today probably because of his guidance that he has given me over the last 7 to 8 years. So by the time I completed my DM, I knew I did everything in my DM. Look, pediatric immunology and rheumatology is a broad field, and I published in every disease. I looked patients with every disease. But by the time I completed my DM, and again, this is the vision of Professor Sujit Singh, he's told me, if you want to go into research, you have to narrow down yourself. And then I realized that I think this is the time I narrowed down myself, my research, and I chose to work on these 4 areas. And I'm going to tell you a little bit about my journey into each 4 of these diseases, but my oration would primarily be focused on Kawasaki disease. So my journey into juvenile scleroderma is not something very encouraging, or I would say it's very new. We have just published 2 cohorts, clinical cohorts of patients with juvenile scleroderma, one systemic scleroderma, and the second juvenile localized scleroderma, which has recently been accepted in one of the journals. But what next? You know, is that the end, that you publish one cohort, you wait for another cohort to develop, and then you publish that cohort? I think no. So we decided that when we were looking at our cohort of patients with juvenile scleroderma, we realized that there are hardly any data on what causes this disease, what is the etiopathogenesis of this disease. Is it environmental? Is it infection? Is it genetics? What it is? So then we realized that let's go ahead and do some work on it. And then we wrote this research project, which was funded by Department of Health Research. And now, in collaboration with the adult rheumatology department in our institute, we are now evaluating the genetics and epigenetics and some viral factors in patients with juvenile and adult onset systemic sclerosis. And Dr. Sanghmitra, who is a DHR young scientist under me, is currently working on this project. And we are happy to collaborate if anybody wants to collaborate on this project. Now, amongst the primary immune deficiency diseases, antibody deficiency diseases are is my main area of focus. And again, we started with few clinical cohorts. So we started collecting pan-India data of X-linked A-gamma globulinemia. Recently, we started collecting data on common variable immunodeficiency across the country, and we published a few unusual clinical manifestations of X-linked A-gamma globulinemia. But as I said, what next? You have to move on. You just can't keep collecting cohorts. And then we started doing some research work. So we have now one ongoing research project on X-linked A-gamma globulinemia, which is likely to finish in next few months. But one of my PhD students is now working on understanding the genetic and epigenetic basis of common variable immune deficiency in the country. And I'm very happy to, I'd be very happy to collaborate on this research project as well. So her thesis work is mainly focused on this disease. This disease is supposed to be the most common primary immune deficiency. The patients move from rheumatology to gastroenterology to pulmonology, all specialty, dermatology, but it gets missed. If you ask me what is the disease that excites me most, so that is hereditary angioedema. But I like Kawasaki disease most because it's one of the most enigmatic disease that I've ever seen in my life. So my journey with hereditary angioedema actually started in March 2019. This was a patient-doctor meeting organized by HAE International. So this is a Hereditary Angioedema International patient organization. So this led by Fiona Wadman. She organized a meeting in Delhi wherein a couple of doctors and a few patients attended. And then we realized the unmet needs of these patients. The quality of life of these patients can be significantly improved. The mortality can be made reduced to near zero. But we have to put in some efforts into doing this. And then that somehow sparked my interest into this entity. And we went on to establish the Hereditary Angioedema Society of India. And I must say that this is one of the few countries, I mean, most developed countries also do not have a dedicated HAE Society of India, HAE Society, but in India it is there. And this society is now led by Professor Sunil Dogra from the Department of Dermatology, PGI Chandigarh. We published a few papers in last couple of years on hereditary angioedema, the clinical profile, the genetic profile, and this is the one about mitigating disparity in healthcare resources is my favorite on HAE, and this paper talks about the disparity that is prevalent in accessing healthcare in patients with HAE, not only in India, but in many parts of the world. And now, based on the efforts by the society, based on the publications that we've written, now at least we have 2 first-line treatment options for hereditary angioedema available in the country. So, so this is the subject of my oration today, Kawasaki disease. So my journey into Kawasaki disease actually started with a simple case report. I saw this 9-year-old boy who was, I was very early into my training, DM pediatric immunology and rheumatology. I saw this 9-year-old boy who had typical Kawasaki disease, and he had this redness on the arm. So this was basically the redness induration at the site of BCG inoculation. So this was BCG reactivation. I immediately took out my phone and took a photograph. Soon after the child was discharged, I asked Dr. Singh, sir, can we publish this case? He said, why not? And I think this was probably the second attempt. So first, I think we tried NEJM, and then this arthritis and rheumatology, this got published. So this was my first, one of my first few publications on any disease, and I think this sparked my interest into this particular entity. So what I mean to say, I always tell my residents, whenever you see an interesting finding, do talk to patient, do everything, but first of all, take a good photograph of that particular finding. And I think all of us who are sitting here will be having at least one photograph in their phone that can easily be published in a good journal. So just to give you a little bit background about this disease, it's one of the most common childhood vasculitis, and we have no doubt about this. We have data on this, that this is the most common childhood vasculitis. There are no good epidemiological data from India, but we have some data from Chandigarh, and of course this is being recognized most commonly in Japan, followed by Korea and Taiwan. Now this is an unpublished work that we have collected over last 1 or 2 years, and we actually looked at all patients registered in a pediatric rheumatology clinic, and out of these, how many were vasculitis? So 20% formed the cohort of vasculitis, and of these, 69% were Kawasaki disease. So undoubtedly, Kawasaki disease is the most common childhood vasculitis across the world. And in Japan, if you look at the figure, at least 1% of all children would develop Kawasaki disease by the time they reach the age of 10. And it's now the most common cause of acquired heart disease in children in the developed world, and I'm sure it will become the most common cause of acquired heart disease in children in India as well. Now I'll focus on some of the controversial aspects that are revolving around this disease based on some of the publications that we have done in last few years. So this is the American Heart Association 2017 diagnostic guidelines, and we all are aware of the principal clinical signs of this disease. And the beauty of this disease is that these principal clinical criteria have not changed at all in last 50 years since Dr. Kawasaki himself described this entity in 1967. So these criteria may go a little bit of changes, but essentially they are same in last 50 years. But what I want to focus on some of the unusual aspects in terms of diagnosis of this entity. So especially for this forum, the question arises, is Kawasaki disease seen in older age group? Is Kawasaki disease seen in adults? So yes, it is seen in adults as well. We published our experience on Kawasaki disease in children older than 10 years, and approximately 5% of all patients with Kawasaki disease are older than 10 years. And what is interesting about this cohort is that these patients, many of these patients actually present with hypotensive shock and may easily be labeled as sepsis, infections, and get misdiagnosed. And because of the misdiagnosis, these patients are at risk of, a very high risk of coronary artery abnormalities. Now, this is one of our patient, adult Kawasaki disease. She is 30-year-old who presented with facial nerve palsy and went on to develop all clinical signs of Kawasaki disease. She was given IVIG and infliximab. Now, another interesting aspect of Kawasaki disease is macrophage activation syndrome. We published our experience last year, and in pediatric rheumatology, Kawasaki disease is the third most common cause of macrophage activation syndrome. Systemic GIA is the first, followed by systemic lupus, and then the Kawasaki disease. Now, most of these patients are very sick. Most of these patients are older in the age group. So younger children tend to develop less of macrophage activation syndrome as compared to older children. And again, they are at very high risk of coronary artery abnormalities. Now, another interesting aspect is arthritis, and again, most of these children are relatively older. Arthritis in patients with Kawasaki disease may develop in the acute stage when they are sick. It may develop in the subacute stage when you've given treatment and they have recovered. So these patients may present with arthritis, which may look like any JIA, and it may create a diagnostic conundrum for the treating physician. Now, Kawasaki disease always gives you surprises, and we have seen patients presenting with acute kidney injury, coming to nephrology. We have seen patients with pulmonary presentation. They present with infiltrates in the lungs, and they present to pulmonology. And these patients, because of these unusual clinical manifestations, are usually diagnosed late and are at very high risk of development of coronary artery abnormalities. Another aspect about diagnosis that I want to highlight is recurrent Kawasaki disease. The recurrence rate is approximately 1% in India. It's about 3% in Japan, but it's not very common in India. The patients who develop recurrent Kawasaki disease are not usually very severe. So the recurrent episode is usually very mild and is usually not associated with development of coronary artery abnormalities. But what I want to highlight, this has been our observation in the last few years, that many of these patients with Kawasaki disease, and this is a very common phenomena, when these patients develop a viral infection 1 or 2 years or 3 years down the line, they start develop periangle peeling of the skin. Now, whether this is recurrent Kawasaki disease or an anamnestic response remain at the judgment of the treating physician. And many of these patients just develop a viral infection, just develop peeling, and otherwise remain well. And this is a very common phenomena, and we have seen this phenomena developing as long as 7 to 8 years after the acute Kawasaki disease. Now, from diagnosis, I wish to move on to the etiopathogenesis, again a very controversial issue in Kawasaki disease. The best possible hypothesis for the etiopathogenesis of KD is that this develops in a genetically susceptible host on exposure to an environmental agent, most likely an infection. But what is that genetic susceptibility? What is that environmental trigger? Nobody knows. There has been a lot of genetic workup done in patients with Kawasaki disease, and there are more than 60 genes that have been identified to cause susceptibility to Kawasaki disease, to increase risk of IVIG resistance, and to development of coronary artery abnormalities. So this is Dr. Yoshihiro Onochi, who has pioneered this work on genetics of Kawasaki disease in last 20 years. So based on family studies and based on population studies, he has identified more than 60 genes that may be associated with susceptibility to Kawasaki disease. We have also done a little bit of work on genetic susceptibility to Kawasaki disease, but these are all small cohorts done in about 50 to 100 patients. And this is one work which was done on CD40 gene polymorphism by Dr. Pratap Patra, who is right now in AIIMS Patna. And there were some associations of this gene polymorphism with Kawasaki disease. But as I said, these are small cohorts, and these need to be replicated in larger cohorts. So this is the study that I carried out when I was doing my DM. This was my DM thesis, and I looked at the expression of CD40 ligand and the soluble CD40 ligand in children with Kawasaki disease. And just to give you a little bit of background, so CD40 ligand is present on the T cells, and it interacts with CD40 present on the B cells to generate an immune response. So this interaction is extremely important to generate any immune response. So what we were expecting is that the expression of CD40 ligand would be high on the T cells, and the soluble CD40 ligand will also be high on the in the serum in the acute stage. And as you treat, the CD40 ligand expression as well as levels will go down. So this is one of the representative flow diagram from one of the patient. And in the lower panel, you can see the patient in the acute stage has a very high expression of CD40 ligand, which is 72%, and in the control, it's just 44%. But to our surprise, the median CD40 ligand levels on the T cells were actually high in the acute phase of KD. They were higher as compared to controls as well as the febrile as well as the normal controls, and they improved with treatment. But to our surprise, the CD40 ligand present on the serum actually increased after giving IVIG as compared to the acute stage. Now, once we got these results, we were surprised, and we wanted to understand what is the reason. Then we realized that CD40 ligand in the secreted form is not only, the T cells are not the only cells that secrete CD40 ligand in the blood. it's predominantly coming from platelets. And as we all know, platelets keep on rising in patients with Kawasaki disease despite treatment till about 6 weeks, and then they normalize. So the hypothesis is that the patients with Kawasaki disease continue to have rise in platelet counts, even despite giving adequate treatment, and as a result, the CD40 ligand in their serum continue to rise despite giving treatment. Now, what is this CD40 ligand doing? We don't know. CD40 ligand has been studied in many vasculitis, including Takayasu arthritis, and it has been proposed to be a molecule that may induce atherosclerosis. And because these levels are rising in patients with Kawasaki disease, it's possible that this molecule is causing endothelial damage despite giving them adequate treatment. And now there is one drug that controls CD40 ligand, and which is atorvastatin, and it's possible that if you give atorvastatin in these patients, it may help lessening the damage to the endothelium. Now, from etiopathogenesis, I move on to the most controversial aspects of Kawasaki disease, which is imaging. We all know that echo is the imaging modality of choice, but it has its own limitation. And as a result, the newer imaging modalities are now taking place. And I'll show you in my slides how these newer imaging modalities have helped us in understanding what is happening to the coronary arteries and what we were missing on echocardiography. So these are the limitations, and we all know that you can't see all coronary arteries on 2D echocardiography. So this is our published experience, which we published very recently on distal coronary artery abnormalities in Kawasaki disease. And what we realized, in 176 patients, we observed 60 coronary aneurysms in patients using CT angiography, while on echocardiography, there were just 40 aneurysms. So we missed 20 aneurysms by just doing echocardiography. And more importantly, 4 of these aneurysms were present in the distal coronary arteries, which you can never pick up using echocardiography. And Dr. Manful, who is the professor in the Department of Radiodiagnosis, has established a very low radiation technique to assess coronary arteries in these patients. And we are able to do coronary artery imaging in as young in children as young as infants. So the radiation is not more than about 6 to 7 X-rays per CT angiography. This is one case, and the images of this patient will show what Kawasaki disease can actually do to your coronary arteries. So this was a 2-year-old boy who was admitted with us in 2007 with typical clinical history of Kawasaki disease, received treatment. You look at the coronary arteries on echocardiography. Initially, more or less okay, but within a few days, they ballooned up and there was large aneurysms in anterior descending and right coronary artery. So these are the subsequent echocardiographies carried out over last few years, and you can see the coronary arteries have more or less normalized, and this is what you can see on echocardiography. But when we did the CT angiography of this patient in 2016, so look at the ballooned out coronary arteries here, but more importantly, look at the level of calcium that is deposited in these coronary arteries. Now, these changes you can never pick up on echocardiography. These are picked up only on CT angiography. And the calcium score in the coronary arteries of these patients is as high as a calcium score that you expect in a 70-year-old adult, or even more than that. So these are the kind of damage that Kawasaki disease does to the coronary arteries. And this is another boy who was admitted at the age of 1, and we did his CT angiography just last month, and you can see those scary calcifications encircling the entire coronary arteries. You can see it here, and you can see it here, the dense calcification developing in the coronary arteries, and you can imagine what is going to happen to these patients in the next few years. Now, for several years, it was believed that the coronary vasculature is the only vessel that is affected in patients with Kawasaki disease. But over the years, we have realized that myocardium is equally affected in these patients. So we did this research. These are the thesis, the MD thesis of 4 students, 3 from the Department of Pediatrics and 1 from the Department of Radiodiagnosis. So we did cardiac MRI in these patients. And the beauty of these studies were, we were able to trace patients even 20 years after the acute stage of the Kawasaki disease. So these cardiac MRIs were done at least 10 years after the initial diagnosis of Kawasaki disease was made. And we divided these patients into 4 different cohorts. 1 who had no coronary artery abnormalities were given treatment. 1 who were labeled to have transient coronary artery abnormalities, thereby meaning that the coronary artery abnormalities regressed by 12 weeks of the acute illness. The third cohort, wherein the coronary artery there were no coronary artery abnormalities, they were mild KD. By the time they presented to us, they had already become afebrile, and they were not given any treatment. The fourth cohort was the one wherein the coronary artery abnormalities were persisting till date. So the findings of this study, these are very preliminary results, and we don't know what to do with those results. But in patients who had coronary artery abnormalities, of course, they were also found to have coronary artery abnormalities on MRI. But many of the patients who had no coronary artery abnormalities, or who had transient coronary artery abnormalities, wherein the echo showed that on follow-up the coronaries have become normal, they were found to have coronary artery aneurysms on MRI. So these were completely missed on echocardiography. More importantly, many of these patients had low ejection fraction, and many of these patients had myocardial fibrosis. Now, we don't know what to do with these findings. These are very preliminary results, but these are scary to us. We don't know how to counsel the parents with these kind of results. Now, next move on to the management aspects. Again, a very controversial aspect. This table shows how the evolution of treatment of Kawasaki disease over the years. And since 2000, there has been a remarkable change, and there has been a trend towards giving intensive treatment to these patients now. And there has been a recent trend that primary intensification of treatment for Kawasaki disease is required in a subset of patients who are at risk of coronary artery abnormalities as well as IVIG resistance. So in our experience, we've given we have started giving primary intensification to many of these patients over last few years. So this is one patient which we managed, I think, in 2020. And this patient came with, this was an adolescent boy who came with giant coronary artery aneurysms. And when we decided to give intensive treatment with IVIG, infliximab, steroid, and cyclosporine to this child, and you can see the regression of the coronary artery aneurysms on follow-up. Now, this is another case who present with giant coronary artery aneurysms. We give him intensive treatment, and over a period of 1 month, the coronary arteries have nearly regressed. Now, we collected these data, and this is unpublished experience, and in 45 patients collected over 3 years who had moderate to giant coronary artery aneurysms, we gave intensive treatment to 14 of these patients in the form of IVIG plus infliximab plus cyclosporine plus corticosteroids, and many of these patients tend to do well, and the coronary artery aneurysms which are supposed to, the giant coronary artery aneurysms which are supposed to never regress, they actually regress with this intensive treatment given to these patients. So this is the last controversial aspect of these patients. So the controversies in the long-term outcome of the Kawasaki disease. So there is plenty of published literature, and we also have some experience from our own center that patients who have no obvious coronary artery abnormalities in the acute stage also have persistent endothelial dysfunction several years down the line. Now, these patients may be at risk of early cardiovascular events in their life, but I think we need to have more data on this aspect. Now, my journey into Kawasaki disease has been very exciting, and I'm sure this will continue to be exciting for me. But my most memorable moment of journey into this disease was when in 2018, I received Young Investigator Award from none other than Dr. Kawasaki himself when I attended the 12th International Kawasaki Disease Symposium 2018 in Yokohama, Japan. So this was my most memorable moment of this journey, when this legend himself gave me this award. And with this, I thank for the patient listening, and I wish to acknowledge my unit and all the clinicians and researchers in my department, and it's a team effort that all this has been done. Thank you so much.
Thank you, Dr. Ankur Jindal. It was a wonderful oration. You very lucidly shared your journey with all of us. Your training in very good institutes, the SMS Medical College, Maulana Azad Medical College, and PGI Chandigarh. I think that really put you on that, track. You took full advantage of it. Your passion about the subject was beautifully brought about and visible. I don't think anybody would have, I'm talking not in the whole age group, because there will be people who will be in it for 30 years, but I think anybody with that many years would have that many papers on Kawasaki. Professor Surjit Singh, I had an opportunity to be with him in a retreat in CMC Vellore for 3 days, and it was one of the most phenomenal experience. And you have studied under him, now with him, I think he's a legendary person. Your core areas of research, Kawasaki, and then antibody deficiency diseases, excellent publications, were very well brought out. I really appreciated the BCG reactivation in Kawasaki disease and the beautiful point you brought out where a lot of people have photographs but they don't go ahead, and sometimes many of them could, help many more to understand. Your perspective on acute kidney injury, recurrent Kawasaki disease, 2D CT angio was very useful, and I'm sure all of us would benefit a lot from that. As this is an oration, there would be no questions asked, but I'm sure there would be many people, including me, who are very keen to learn more from